trying this again, keep having technical difficulty with my microphone, and I don't realize until I'm too far in and have a bunch of computer issues here. So hopefully this all works out okay. I'm going to do a video talking about the process of obtaining an arterial blood gas sample. So we're not going to talk about why we're getting an ABG. We're focusing on the how here right now. But one thing I would tell you to remember is you need to make sure you have a clear clinical indication for obtaining this sample. This isn't some non-invasive test that should be performed on everybody. There should really be a true need for obtaining this sample here. So kind of keep that in mind as you go through. Before I actually get into the puncture, I'm going to talk about the equipment a little bit. I'll show you this in lab. You need to become familiarized with the type of equipment your facility has. Okay, every place is going to have stuff that's a little bit different. Hopefully you find some similarities. You have something like this where it really doesn't come with everything you need for the puncture, and you got some that are a little bit bigger and they do have everything you need and then some for that puncture. All right, so become familiarized with what you need. Ultimately, we need a heparinized syringe, and if you read on these, it'll tell you that that has dry lithium heparin. We can't accept blood or run blood through a blood gas analyzer or send somebody else to do so without that blood being in a heparinized syringe. If it's not heparinized, it could clot, it could block up those analyzers, and we could run into some issues and take a long time to get it all flushed out. All right, so make sure you have that straight. The other thing you'll kind of look and see, now you probably can't see it really well. Yeah, you should be able to. You'll be able to see the contents of this. All right, it tells you these bare bones kits have a 23 gauge, 1 inch long needle. All right, gauge is how large that needle is as far as thickness. The smaller the number, all right, the bigger it is, and the higher the number, the smaller it is. Most kits, the largest needle you're actually going to see is maybe like a 21 or 22 gauge. A lot of times you might see like a 23 all the way up to like a 26 gauge, okay? Kind of depends on the kit. Why is that important? Well, sometimes if you're trying to go and you get a brachial or a femoral and somebody's got a lot of mass, you might need a little bit of a longer needle than the standard 1 inch that comes in some of these kits. And you ask a nurse for a needle, they're going to give you all these options. So it's good to have a basic understanding of what size needles we're using. You don't want to get something that's bigger than the artery itself, and then it's just a whole big ordeal there. Some of these kits, all right, come with 2 needles. So if you read on this, it's got a longer 1.5 inch needle that's a 22 gauge for like a brachial stick or femoral stick, and then it's got a 23 gauge 1 inch needle for standard radial, which radial should be our preferred kind of go-to there. So we need a heparinized syringe, appropriate needle. There should be something to protect the needle at the end, okay? So like with these, this is just a little clip guard that once we're done, we can push that on the bed and it locks the needle into this device so you don't get stuck by a dirty needle. Sometimes you don't have this and you're gonna have like a little red rubber stopper that you stick the needle in, thread your syringe off of that thing, and then you're good to go. So you're gonna need something like that. You don't wanna be recapping a dirty needle or walking around with a dirty needle like a dagger or anything. You're going to need something to prep the skin with. Clinical practice, we're either using chlorhexidine wipes and or like an alcohol prep pad wipe. Some of your kits come with an iodine. Very seldomly kind of use that, usually chlorhexidine or just a straight up alcohol rub. You're also going to need a piece of sterile gauze. So some of the ones that are a full kit, it's going to come with a little sterile gauze 2x2. If you don't have the full-blown kit, you're just going to have to grab one of these as part of your prep for this. Okay, come in a little package and just try and keep it as clean as possible. It's not going to be sterile by the time it's all said and done because it's skin we're dealing with, but you want to kind of start out as sterile and clean as possible. You're also going to need something to secure that dressing. Okay, so we're gonna hold pressure until this thing stops bleeding, but we still want to put some sort of a covering over that thing. Some of these kits actually come with a Band-Aid, which is unique. I haven't had too many that do. So if you don't have this, grab a little piece of tape and be able to tape that piece of gauze over that whenever you're done. You also need a biohazard bag. So some of these kits come with it. Sometimes you're having to grab it. You're going to need this to transport that specimen or send it through a tube system for somebody else to run it. You can't be walking through the hospital with just bodily fluids in a syringe that violates some policy. So you need a biohazard bag to place that in. You also need a patient label or a lab requisition, something with their name on it, and that's going to go directly on this specimen itself, okay? You can't just put it on the bag. If you want to put one on the bag too, that's fine. But once that sample comes out of the bag, it's not labeled anymore, and that could be an issue. What if you get a phone call or set it down? It could lead to some problems, and I've had that happen as well, okay? So it's something to take into consideration. Likewise, sometimes these kits come with a little card. It's important to note how much oxygen they're on, what type of ventilator settings, what vent measurements, and things like that. because the thing to remember about a blood gas is it's only a snapshot in time, okay? It doesn't tell you what's going on with the patient right at that moment. It tells you what was going on at the time you got that blood gas. So if you don't know what was going on fully with their oxygenation and ventilation, hard to make an appropriate informed clinical decision here. So all of these syringes that we deal with in modern practice here locally, and I've still encountered, and it's been a long time since I've seen something called a non-vented syringe. We have what's called a vented syringe, meaning if you're looking at this barrel of the syringe, it's got volume markings, okay, we got the actual needle, the hub, this is like the little plunger right here. So with a vented syringe, you actually pull back to whatever volume of blood you want to obtain from that patient prior to starting this procedure. The non-vented syringes, all right, you would actually just go ahead and stick, and you can't have a volume of air because there's no way to evacuate the air. What vented means is we could have that air in there, and as blood starts to fill through, it's going to push air out the back of this through that vent until it hits that little heparinized disc right there, and then it's going to go ahead and seal the system. So we want to draw back to our volume of blood we hope to obtain. Usually a mil and a half is pretty good. They do make these tiny little tuberculin syringes that are only 1 mil large, or 1 mil volume in total. With those, I'll usually only get about 0.8 because I don't like having that thing all the way, that plunger pulled all the way back where it's almost coming out of the barrel of the syringe. Get familiarized with the analyzers your facility uses. Our idea is, even a mil is too much blood than what we need to typically run that test. We want to have enough to safely run a second time if something happens, or air with the analyzer or something along those lines, okay? So get familiarized somewhere in that kind of 0.8, 1 mil, 1.5 mils of the utmost max. We don't need to draw 3 mils or out of that. Okay, that's going to be way too much. So I'm going to go ahead, I'm going to draw back to we'll split the difference. We'll do like 1.2 here and just kind of looking at the measurements. So once again, this little orange piece, okay, is designed to clip over the needle once we're done with the puncture, because we're not going to try and put that little protective cap back over like that. These particular kits, okay, that's just a slip fit. Sometimes some of these are what we call lure lock, and these are a little bit better because they stay locked in a little bit more. They're not going to give you as much headache. So this little piece just kind of slips on here, and the needle is also just kind of a slip-on. So the first thing you really have to do once you're in the room, we'll talk about patient identification and stuff, just talking about the equipment side of things, I'm going to show you how to kind of get this needle prepared here, okay? So what you want to do is get that cap off and have it on there loose so you can just lift this up and the cap kind of falls off here. And usually we're doing this after we've kind of identified a patient and talking to him. We'll talk about that part in a second. These caps come on very, very firmly, and because this is a slip fit, if you pull, the whole thing just kind of keeps coming off. So I'll take that thing off and just wiggle it a little bit, and be careful. People will pull really hard, and then it goes to give, and then they jump forward and they poke themselves. It's a clean needle poke, but you still don't want to poke yourself. So you want to get that nice and loose, and then kind of firmly place this on here. I'm going to go ahead and show you something about the needles, and it's hard to see this, but you can see it's kind of cut at a 45 degree, or what we call a beveled cut. You're not going to be able to see, it's going to be all fuzzy, meaning that thing's cut at 45 and there's a clear opening. We want that opening to be facing upstream in that arterial vessel, so blood flowing towards it. It's going to enhance that filling, all right? Sometimes we miss that first puncture, and we maybe have to redirect. It's important that we know how that bevel's oriented at all times. So most of the facilities I've worked, we've used these particular kits on a routine basis with this little needle protector. I always orient that piece of orange plastic in the same direction every single time I set this up when I'm comparing it to how my bevel's facing. So my bevel's facing like this right now. I have this always in the 3 o'clock position when I'm sticking, and that helps me if I go to mess something up, or not go to mess something up. If I mess up and I'm trying to redirect and get it, I always know how it's facing. The reason I choose that 3 o'clock position is I'm always sticking with my dominant hand. I mean, I can go left, but I prefer not to. That allows me to watch the hub right here for the flash of blood that lets me know in the artery. All right, likewise, it doesn't get in the way of the skin. If I had this downward like this could hit on the skin and kind of mess up my trajectory. Likewise, sometimes you're looking from above. If you had it kind of pointing at the 12 o'clock position, it can get in the way. And if I had it pointing like this, it would kind of obscure my view of that hub. So I want clear visibility of my hub at all times as I'm doing this procedure. Once you get this cap off, you should never recap by hand. You would set this down and do something like this so you don't stick yourself. And then once I get my syringe all set up and everything like that, my needle, I get it there really nice and loose, and I kind of set it down. we should be identifying the patient, kind of explaining who we are and why we're getting this test, okay, to the patient. So checking a wristband, making sure you got the correct patient. If they're alert and oriented, you can ask for identifiers as well. Some places you actually have to scan them as you're getting this blood gas. So every place is different. So you'd be checking that patient. And usually I don't care what side I go with. I'm fine with whatever. I'm opportunistic. So if it's really easy to move in and get to the right side, I go that side. I can go with the left. For whatever reason, I feel more comfortable sticking the right hand, but that's fine. Some people ask them what hand dominant you are, and they'll go with the opposite in case something happens. I don't go that far. I'll ask them if they have a preference, and if they say no, I'll just go with whichever. So once you've identified that patient, kind of explained why we're doing this, and it's arterial blood and not venous, okay, and you've picked your side. We're always trying to go for radial first. I'll usually still try and feel and make sure. I'm going to turn my motor on here. I still go ahead and try and make sure. There we go. I'll make sure I can feel a good palpable pulse on the side I'm going to kind of be picking on here, okay? If I can't feel a really good pulse, it's kind of iffy, I'll maybe check the other side. Sometimes it's just maybe a little stronger on one side versus the other for a particular patient. Once I feel pretty good, we're going to go ahead and do the modified Allen's test. This ensures collateral circulation. You'll see people scoff at this. It doesn't take time to do, okay? And it's really ensuring that if something bad happens, you're going to be okay. What we're trying to do is occlude both the radial, so on the thumb side, and your ulnar arteries. The ulnar is a little bit deeper here. We're trying to occlude both of those, and I got my gloves on, so it's not going to make sense. This guy can't follow it, so we'd have to actually hold his wrist up a little bit higher than his heart for a moment. We're trying to occlude the blood flow and drain everything out and get that hand kind of discolored, right? So a little bit lighter in color, doesn't have that blood. What we're trying to do, so like if you're doing this on me, I'd occlude my radial and my ulnar. All right, get firm grips, have them pump their hand to drain some of that blood out, and then we're trying to simulate if the radial artery was severed. So you're going to release pressure on the ulnar side and keep that radial occluded, and we want to see that hand get nice and pink to back up in a relatively short period of time. If it doesn't, that would be a negative Allen's test, and you should not stick that side. If something happens to that radial, whether that's vasospasm, whether that's shearing of the artery, whether it's a clot breaks free, something like that, you would lose perfusion of that hand, and that you could ultimately lose that hand. We don't want that. Even though you might be working with somebody and go, oh, I don't do this. We charge for blood gases in most facilities, or the puncture. Most places I've worked, I'd have to confirm what side I did in a positive or negative Allen's test. So if you're documented and you didn't do it, and something bad happens, you're hanging out to dry there. All right, so I do the Allen's test. If that hand pinks up, good. That's a positive Allen's test. I got collateral circulation here. What I like to do is I do try and get my patient as comfortable as possible and prop that wrist up so this patient's wrist comes naturally like this. Sometimes I'll grab like a pillowcase or a towel, a wash rag, roll something up, and get that arm kind of extended. We want that wrist kind of extended like this. If you hyperextend too much, it can actually dampen that pulse. If you just leave their arm straight like this, okay, it maybe doesn't bring it up superficial enough to the surface. So I'll kind of feel on that pulse, and I'll manipulate their wrist while I'm kind of feeling that radial artery and seeing what type of position gets it in the most optimal place as far as puncturing goes. I try and make myself comfortable, so it's not uncommon for me to pull up a seat or a chair or sit on the edge of a bed or something like that. If I'm uncomfortable and I'm hovering and standing, I mean, I can still stick somebody like that, okay? But if I'm doing all that, it puts me at risk for not being successful in my puncture. So I am slow. It takes me a little bit more time. Once again, I can go fast if I need to, but I'd rather take a little bit of time, get myself comfortable, and be successful in my first attempt rather than struggle to get this thing and put the patient through torture and things like that. So I've identified them. I've done my Allen's test. I'm comfortable. I try and orient myself, almost like a perpendicular type orientation to the wrist. And the reason being, if I'm way off to the side here when I start sticking, it's easier to overshoot different directions. So I try and make sure that I'm perpendicular, meaning the artery's running this way, and my arm and everything like that, my body is kind of facing directly upstream for that. It's going to make sure I don't mess up on my angles or anything, shooting too far to the medial or laterally. So you want to make sure you got all your equipment set up and ready to roll. You'll see people, they take all this time feeling and feeling. They finally find it, and it's like, okay, I got it. And then they stop and get their equipment set up. You don't want to keep taking all that time, so I get everything set up and ready to roll. So I'm not had too many sites where you have a Band-Aid to get set up here. Usually it's a piece of tape, but I gotta have a Band-Aid. I try and leave as much of the stuff as I can in the actual package that comes with everything, because you'll lose stuff in the bed. I want to make sure I got gauze readily available. I have my Band-Aid or a piece of tape right here. I usually stick that onto the, if I was using tape, stick it onto the table. Don't lose your cap. All right, if we lose our cap, we can't seal our sample afterwards, and we're going to run into a problem. And then I'd have a patient label in here as well, whether I stick that right there, stick it on my badge or my shirt or something like that. And then a biohazard bag can kind of be wherever. You're also going to want to make sure you have your alcohol prep pad, so this prepares that patient's wrist and skin site. Make sure we're not going through dirty skin and injecting something into their vessel here. Okay, so let me open this thing up. Once again, you do want to wear gloves with this. Eye protection is not a bad idea, especially if you're going to have bad technique. I've never worn eye protection, but it's not a bad idea. If something happens and that needle comes out, you could get sprayed. We're going to simply kind of prep that skin site right here. This could be alcohol wiper, it could be chlorhexidine. And I usually get my fingers too if I've been touching some stuff. That just gets everything nice and prepared. For radial sticks, okay, I use one finger. It might look like I have two fingers on there. And if you're just putting the pads of your finger on the top, you may not really be able to pinpoint that thing. I try and pull my glove all the way back, and I try and find the tiniest little part of my finger. Everybody's kind of got a sweet spot where you're going to feel that pulse the best, so don't just as soon as you feel the pulse go there. Feel around and make sure you can find that kind of point of maximal intensity, so to speak, in that radial artery. Once again, kind of play, manipulate stuff, and get that thing positioned as best as possible. What I find clinically is if you took two fingers and put it at the base of most people's wrist, right like that, usually somewhere where those two fingers are is going to be the appropriate place to try and find that thing. As you go further upstream, okay, so more proximal stick, especially if you go past where my second finger is, that thing does get larger, but it also gets deeper. The most superficial point, likewise, you might feel it really, really good right here, but you also feel there's a lot of bone. We want to try and get into this little sweet spot in your wrist. I'd urge you to kind of feel there. If you go too far medial, you got tendons and all this stuff and nerves. If you go too far laterally, you have your radial tuberosity right there and bone. There's a spot in between. If you feel it's kind of opened up, that's where we want to be sticking for. All right, so I got my alcohol prep done. I'm gonna hit my fingers again since I was kind of touching stuff. I got my syringe all drawn back here. Done my Allen's test. I know I got the right patient. You can see I went ahead and I just dropped that, and that allowed my cap to slide off my needle. I know how my bevel's oriented because of my little orange piece right here. I'm gonna go ahead. I try and rest my hand in their hand, and I take my other fingers, even though I'm really feeling with just the tip of my pointer finger, you know, I'm really pinning their hand down with my other fingers on my left hand. That way, if they go to jerk, I'm not getting stuck. Okay, so you want to kind of make sure you're stable. If you're all like this, you're gonna be moving all over the place. So I'm not gonna stick or bring that needle close to them until I'm really comfortable with stuff. If I wanted to leave that cap on there and right here, that's fine. But I'm ready to roll as soon as I feel that. Okay, if you're worried about losing your gauze, and once you get them all set up, a lot of times I'll put my gauze pad up here too, so I'm not reaching or losing it in the white colored sheets. So I'm going to go ahead and feel. This mannequin is a little bit different. You might find it closer to where your second finger is. Up here, that thing takes a dive down into this wrist. We want to be cognizant of the angle of insertion, okay? So not only how the bevel is facing, and that I'm perpendicular to that vessel and hitting straight down, smack dab in the center, but I want to make sure I'm hitting it at about a 45-degree angle. If I'm too flat, like an IV, and I'm going like at a 30, it's going to hit that artery and roll, okay? The artery's got that thick tunica media layer that allows, constriction and relaxation, so you're not going to puncture it. Likewise, if I go straight 90, I might go straight through that vessel in and out and never have a chance and never get my flash of blood that I'm looking for. All right, so 45 or roughly 45 is pretty good for a radial stick. That's going to get a little bit more steep as we go brachial and femoral. I'm going to try and make sure you can kind of see what I'm doing here. So I'm going to go ahead and feel. I go right in front of my one finger. Some people do two fingers and try and pin it down from both points and go in between for the radial. I always use one finger, and I found it, I get the best success that way. So I'm going to go ahead and feel. You're going to apply a little bit of pressure, okay? If that vessel disappears, just realize you can have it completely occluded. So push, and then kind of slowly back off, and then sometimes like, oh, okay, I couldn't feel it because I was pushing too hard. And make sure you find the spot where it's really the best, okay? And try and get the tiniest point and tip of your finger where you really feel that thing. So really, I'm just feeling with my one finger, even though I got my other fingers on the back kind of holding that hand down. So I kind of rest my hand in their hand so they can't go away. And then once I'm really comfortable, and I think I got that thing pinned down, all right, big stick. I'm going to try and do this in a weird manner so you can kind of see the flash of blood maybe. All right, big stick. I'm going to slowly insert. I'm keeping that artery pinned down until I see a flash of blood in the hub. I would leave my finger on that, but I just wanted you to see that that is automatically filling. I got the pulsatile filling. As soon as that reaches the back, all right, all done. I'm going to go ahead and pull that out while I'm putting gauze on simultaneously, applying firm pressure. You can see I got my sample of blood here. What I was trying to refer to is you would look at that little blue piece right here, and that's all I'm watching. I'm watching how I'm going in. As soon as I see a flash of blood, I stop. And I want to see that pulsatile filling and that syringe filling up with bright cherry red blood. Once I'm done here, I'm going to go ahead, use the table to click that down. That takes that syringe, all right, or the needle on top of that syringe, and it protects it. I'm holding pressure with my left hand. If you got massive air bubbles at this point, I always do a little shake or a little twist so you can kind of tap it on there and try and get the air bubbles at the top. Sometimes you have a stubborn one, I'll draw back on there and try and get all the air bubbles kind of uniform. And I'll kind of push a little bit, something like that. You don't want to push too hard and spurt blood. We're going to find that cap. I usually put it on a table or a firm surface. Push really nice and snug. That is not enough. We actually need to shoot this up. That, as soon as that gets wet right there, okay, that is going to go ahead and it seals the system from above. That pad got back wet from blood on the back. That's sealed. This is going to avoid pre-analytical errors. It's going to avoid air contamination, influencing our PaCO2 and our pH, as well as our PO2. All right? You can give this thing a little twist and a roll, make sure everything's nice and heparinized. I usually do that once I get that thing pulled out to make sure that I got all the air bubbles out. And I'm really just holding on pressure, okay? So there is no time or anything like that you're holding pressure for. You're holding it until the bleeding stops. And I'll show you my little trick. Somewhere that could be sent anywhere 2, 3, 4, 5 minutes. A lot of times if you have the opportunity, looking beforehand and seeing what their coagulation studies are showing, or if they're on blood thinners or something like that, it can be helpful unless you know you need to hold a little bit longer. That still doesn't change the time. We're holding it until the bleeding stops. All right, and I'm applying firm pressure. If you just barely have a moment of time or you don't have enough pressure on there, whether that's you pull out and then put the gauze on instead of doing it simultaneously like I showed you, they'll get a big hematoma, and it's inappropriate. It's going to be problematic the next time they go to get that, and they're not going to like you very much. All right, so let's say it's been several minutes. I don't know if the bleeding stopped. What I do, I know that the spot where I'm holding pressure on it is going to have blood on it. I just go ahead and intermittently roll that gauze and kind of change it, and I go to a spot where that gauze is clean. Here in another minute or something, as I rotate that gauze, I'm just observing and seeing if I got a little specks of blood. If I still see specks of blood on it, it's still bleeding. All right, so I just kind of slowly rotate that piece of gauze, and then I'm kind of checking where that was touching the skin, and as soon as that bleeding is stopped right there and I get a dry little patch of gauze, I'm probably pretty good. I still put a bandage on there, okay, so in this case I'm going to leave their gauze. In real life, it'd be taking a little bit longer, so we would go ahead and put the patient label on and stuff like that. The main thing is not leaving the room with the specimen unlabeled. I'm going to go ahead and put their little Band-Aid on. All right. This guy's got a lot of slather on him, so it's not going to stick very well. I'd leave that on, give him the wrist back, ask if there's anything else I can do for him. I'm going to go ahead, take my sample, I'll put my label on there, and put it in a biohazard bag. In clinical practice, we don't generally ice our blood samples unless we know that it's not going to get run right away. Even when you're tubing these down, all blood samples are run, ABGs are run as stat. If you're doing point of care, I'd have a patient label on here. I'm going to go and run that right away, so there's no ice necessary to slow down that metabolism. Depends on where you're at and how long you think that blood's going to take, though. Generally, if I am somewhere where they're not going to run it in 20 minutes, I think 30 is the utmost max on that. You need to ice that sample to slow down the metabolism. I go ahead and clean my mess up, so usually you don't want to just throw a needle in a trash can, or if you have multiple syringes, every room's going to have a sharps container. You go ahead and drop that needle in there and then be done with it, okay? I'd make sure I know what oxygen devices are on, what their ventilator settings are on, and I go and run this. All right, so that's what happens if we are actually successful and we get our sample. Let's talk about what happens if we don't, because this happens even when you do everything correctly. So let's say I've already prepped their skin, everything's all good here. I'm going to try and see how I'm going to move my filter guard to the other side, or my needle clip guard to the other side and break my rule, so hopefully you can see here. So let's say I've already done my Allen's test as the same patient, but I just pulled that needle out and I was unsuccessful. So I got a second kit. Once you pull that needle out, you can't stick that back into a patient, okay? That counts as an attempt. You need to get a brand new setup here, whether that's a brand new needle or whatever. You can't reuse that same dirty needle, okay? You need to replace that. So let's say I got a second one here. I got my gauze pad. I already prepped. We'll say I'm wiping again. Allen's test is still good. I'm trying in the same spot. I think I was messed up on things, okay? So I got my bevel facing the correct orientation. I'm kind of feeling around. I'm going to see. Hopefully you can see enough to get, move my camera a little closer here. See if you can see it a little bit better. All right. So I'm going to intentionally try and miss here, and I'm going to try and hold it like a weird. I hold this thing down really close like a pencil, okay? You'll see people that hold it all funky and back here. That's not going to work. You need really, really fine tip control. I'm going to intentionally miss here, okay? So I'm going to go ahead. All right, big stick. I'm watching for a flash of blood, and I don't get it. All right, if you think you're right there, so as you're advancing, and it's like, man, I'm not getting it. I don't see the flash of blood, so I'd be looking at my little hub right there. Let's say I don't get that flash of blood. Think real close. Do I really feel like I'm in the right spot? If you're like, man, I feel like I'm in the right spot. My angle's good and everything like that. I don't know what's going on. Ask yourself, if you feel really comfortable, slowly let your finger up on that vessel. Sometimes you have it clamped so hard that blood can't go through it. And then just watch that hub for that flash right there, okay? If you see it, as you let that finger off, you're good. You're just a little nervous and pushing too hard. Let's say I tried that, and no, still nothing. Okay, I see what I did. I wasn't running perpendicular to that vessel. I shot too far like this, and I probably overshot that. What I'm going to do is try and pinpoint that pulse again with my finger and go, okay, here's my spot. I'm going to slowly draw back till about the sub-Q, okay? So that bevel and everything shouldn't really be sticking out of the skin. I'm pulling out where I'm almost all the way out, and this is something you got to practice with. I'm trying to show you on here, but it's hard because it's so up close. Almost to the point where I'm pulling out. I'm slowly bringing that around, okay? Making sure that I'm only moving the back end of this plunger here and redirecting. And then I'm going to kind of slowly advance, and I'm watching for my flash. I'm going to try and hold it weird so you can see my flash maybe in the bottom part of the screen. I'm going to kind of slowly advance, and then you can see, and I wouldn't take my finger off the vessel, you can see I got my blood, and that was a redirect. If it's filling and then all of a sudden it stops, just advance a little bit further, and if that doesn't work, pull it out a little bit further. You might just be going in or out of that vessel and not fully in, or you might come out the backside. Then I can go ahead and pull that simultaneously. Holding firm pressure. I'm going to take this thing off here. This kit is weird. This one's a lure lock, so I actually have to screw this off. Not all of them are like that. And then I'm going to go ahead and put my cap on here. And if you didn't have a tabletop or something, you get used to working one-handed, and you can do some weird stuff like this. So I got a little air bubble right there, so I'm going to give that thing a little tap to try and get it to the top. And then kind of slowly push that up until I seal it. Still holding pressure. Put my label on. Talk to the patient. All that good stuff, okay? Holding this until the bleeding's done. Do my little fold over. See what's going on. Bleeding stop. Put my bandage on. Throw away my work. Put it in a biohazard bag and go run that thing. Okay, so that shows you how to successfully get a blood gas. It shows you how to troubleshoot if you're having issues and not getting the blood with a redirect. The thing you got to be careful about when you're down there in that wrist is that needle is super sharp. You should never be moving sideways with that needle. That bevel's like a razor blade. Likewise, up and down, okay? When you're in the skin, it should only be an back and forth kind of motion like this and not doing it repeatedly. The Singer sewing machine method, right? It's a gentle advance until you get it. If you need to slowly withdraw out a little bit or advance a little bit more to get it, that's fine. If you can't get it, and this is where it takes practice, pulling out to that sub-Q without pulling that needle all the way out. The only thing I'm moving is the back end. I'm not changing like this. I'm just swishing this over like this and then redirecting and giving it a shot. Most of the time, therapists abide by the 3 strikes and you're out rule. If you can't get it on a 3rd puncture, don't keep torturing that patient. Call somebody else. And I hope that helps. I'm not going to talk about pre-analytical errors and everything like that, but hopefully you understand the importance of sealing that system and getting any air bubbles out. That is for a radial puncture. All right, for a brachial, we could go a little bit steeper. So like if we had no positive Allen's test on the right or left side, or we couldn't find a palpable pulse, we could go brachial. There is no collateral circulation there, but the vessel's bigger, less likely for bad things to happen as far as vasospasm occlusion. But if you do screw up, I mean, you lose everything distal to that, so it's not to be taken lightly. With those, I usually do more like a 60-degree angle. And on the brachial, I do a 2-finger, and I go between because it's a bigger vessel. Femoral is straight up and down, doing a 90-degree. Some people do pedal sticks. I try and not do pedals unless it's a burn patient. I have no other options just because it's hard to stabilize that foot, and I don't like hospital feet. I've been like borderline kicked while I'm trying to get a blood gas, and I don't like that. So I hope this video helps, and we'll practice this. I'll demo it in class, but you have this as a resource. So.